Hi, my name is Sarita.
And my name is Rena.
We are both past patients with Mexico Bariatric Center, and we are here to break the stigma of having weight loss surgery in Tijuana, Mexico. We will be covering all things bariatric to help you get the most out of this weight loss journey. Hello, friends.
Hi, friends. Welcome to Can You Stomach This?
Can you stomach this?
What are we stomaching today?
Today, we're stomaching. This episode is going to be about the RNY bypass and the mini bypass.
So let's talk bypass.
Yes.
What? Can you stomach this?
Yes, I can stomach this. I didn't have a bypass, but I can stomach it.
I can stomach this. Let's do it.
All right.
Okay.
So, what is a bypass?
What is a bypass?
Well, there are different types of bypass.
Right.
And we are here to help you make a more informed decision about which one is right for you.
This is so true.
Yes.
Excuse me. Okay, so before we dive into bypasses, let's talk about, to better understand a bypass, let's talk about what a bariatric surgery is, right? So there are essentially two types of, well, we say there's three, but we'll explain. So a bariatric surgery overview is bariatric surgeries are restrictive,
right,
and malabsorptive.
And then you have your combination.
Right. And we'll talk about that. So first we have restrictive, which are what?
We have the gastric balloon, the ESG, which is the endo sleeve. We have the VSG.
Yep, restriction.
Right. These are all restrictive.
Yep.
And we have the single incision.
Yeah.
Which is a sleeve.
Right. And what do they do?
So the restrictive procedures restrict the stomach's capacity, reducing your calorie intake.
Right. So that is restriction.
That's restriction.
Right. And all of those actually remove a portion of the stomach, cantaloupe to banana, except for the balloon, which is actually inserting an object into your stomach. Right. And there's a whole other episode on those restrictive surgeries.
Yes.
So check that out.
Yes.
Check that out. And so the next part of a bariatric surgery, or next type, is going to be the malabsorptive. I struggle over that word. I'm really impressed that I said it because I usually can't.
Malabsorptive?
Yeah, it's that BT combo there, malabsorptive.
I'm used to saying malabsorption.
I know, me too. Okay, so anyway, the malabsorptive and combination. And so, what are those?
So the malabsorptive and the combination bypasses and duodenal switch or duodenal switch.
Right, depends on where you're from, how you say it.
Right. So I say duodenal.
I say duodenal.
And we're both Georgia peaches. So
We are. Yeah. So I've actually heard, and this isn't the DS show here, but I've heard professionals say that name both ways.
Me too.
Yeah.
We can call it DS.
It is DS for short. For sure. And so these surgeries reroute, rearrange, or remove part of the digestive system to reduce your body's absorption of calories. So you have the restriction, which reduces the size to do that. Then you have the malabsorption. And so combo is going to be a combination of the two. And so currently there are no procedures that are just malabsorptive. They are all restrictive or malabsorptive. So anyway, but the malabsorptive procedures produce more weight loss.
Right.
Because of that malabsorption. Right?
Yes.
Okay. So, why would a person have a bypass?
They would have a bypass. Well, there's several different reasons why they would have a bypass.
Right.
They can do a revision. They may not have lost all their weight from the VSG, vertical sleeve. They may have acid reflux. They may have gained weight from, sleeve.
Right. So I was one of those people. I had VSG. I lost my statistical weight with it, exactly 65%. And then I hit a wall. And so I couldn't lose any more weight. so I did a revision. I did not choose a bypass. I chose the DS, but that was an option for me because the VSG is so revisable.
Right.
And so another reason, if you have a virgin surgery, would just be the more aggression. So like even if you have never had a procedure before, and there's a reason that you need a more aggressive surgery, then you have that choice.
Right.
So let's dive into the two different types of bypass. You ready?
I'm ready.
Can you stomach this?
Yes.
Okay, let's do it. Let's do it. All right. So what's our first one?
So the first one is going to be the RNY bypass, known as the gastric bypass.
Yes, that is the one that if somebody says, I had a bypass, they're probably talking about R and Y.
Right. Ru and Y means Y. So it's in the shape
Shaped in a Y.
Y.
Your intestines are shaped in a Y, specifically.
Yes.
Right? And so it is a laparoscopic procedure.
3 to 5 incisions.
Yep. I would say all of the bariatric procedures have 3 to 5, except for Stills, which is
2.
Single, which is 2, technically.
Right.
Another episode. And so let's talk about what the RNY really does, like with your stomach. Right? So I love to explain it like this. I like to picture cartoons when I talk about things. Okay? So like I'm picturing a normal stomach is a cantaloupe, right? It's a cantaloupe. And then you have a gastric sleeve, and you're going to have a banana.
I have a banana.
I have a banana. Okay, but if you have an RY, then you get an egg. So you have a tiny little egg for a stomach.
Very tiny.
Yeah, and that's the stomach that you get with RY. And so what that does is it makes a tiny little pouch, little stoma is actually what it's called. Stoma. And it does not remove, like with sleeve or mini bypass, it does not remove the other part of the stomach. It just detaches from it. The stomach stays in there. And so then it makes that little pouch, and then it attaches the small intestine there, and then shapes them. And there's 2 different connections. So that's where the Y comes from. And by removing that portion of the stomach, it removes that hunger hormone.
Right.
The hunger hormone is produced in the stomach lining of that larger part. And so that's what happens. And then by rerouting that intestine, the routed like a Y, you've created malabsorption.
Right.
So that is technically how it works.
Right.
Does that make sense?
Well, yeah. Food will bypass the small intestine, reducing the amount of calories and nutrients that are absorbed.
Right.
And that's where the malabsorption.
It is. Right. So
some of the pros for this procedure, it will help reflux.
It will help reflux. If reflux is caused by like a genetic disposition or esophageal cancer, then RNY is going to be your surgery of choice.
Right, because you have a smaller stomach, which equals less pressure.
Right, exactly. And this food doesn't stay in there very long. It moves right through.
So tiny.
Speaking of the stomach not staying in and moving right through, it can potentially help sugar addicts.
Yes.
So if you have a sugar addiction, it can potentially create dumping syndrome.
Dumping syndrome is not fun.
No.
Nobody wants it.
What is it?
It's
what
like
does it
death.
do? What does it feel like?
It's like you break out in a cold sweat.
Yeah.
And you get really hot.
Okay.
And you might throw up. You might feel nauseous, diarrhea. I mean, it comes on very quickly. But there's also late dumping, which that can happen too. But it is not something you ever want to happen to you. I've had it once.
I like to explain that it feels like...
Well, that's how it felt for me.
Would you say it felt like a stomach virus on steroids?
Yes.
Yeah.
I'm like, what is happening to me?
I like to use that as an example.
Yeah.
And so you did have it with sleeve. It's very rare to have dumping with sleeve. And she got it from liquid sugar.
Coffee creamer.
Yep.
The first time I tried coffee at 3 months post-op, I used a regular coffee creamer, and I immediately thought, what have I done?
Right.
What's happening?
And so what is happening? Let me tell you what's happening. And remember, I like to I like to visualize things in cartoons. This is going to be an amazing cartoon. I should really write this cartoon. Okay. You want to know what happens? You know what happens? Okay.
You're going to tell me.
I love this.
I've lived through it.
Okay, and so this is how it happened with you for sleep. So what happens is sugar is broken down in the stomach, right? And so with R&Y, you have an egg now. You have a little pouch, and it moves through, your food moves through pretty quickly. And so since sugar is broken down in the stomach, and now you have this little stoma, it's going to move from the stomach into the intestine faster than it can break down the sugar. Intestines don't know what to do with sugar. So when the sugar gets into the intestines go, hey, whoa, what is that?
We're getting rid of it.
And they dump your system. They're like, we don't know what to do with this. Can you picture a little cartoon with like this sugar little bug coming down and the intestines being like, ah? I think it would be hilarious.
Well, I lived through it.
Okay, well, the cartoon explaining it would be hilarious.
Right, that would be hilarious.
Not the dumping syndrome itself. And so with you, with sleep, it was liquid sugar, and liquid moves through your stomach faster, which is why that sugar got down into your intestines. Yes. And so that's what dumping syndrome is. And so you can't have this surgery and depend on dumping syndrome fixing a sugar addiction, though. We do actually know of a lady who had the surgery just to get dumping syndrome because she had a sugar addiction, and she wanted the sugar addiction to teach her not to eat sugar.
Yes.
What happened to her?
It didn't happen to her.
It didn't work.
It didn't
for
work.
her. She still could eat the sugar.
She can eat the sugar and not have dumping.
So it's not really a deciding factor, but it can help.
Right.
It can help. And so another pro to it, I guess, would be it statistically has the same results as the mini sleep. So that's
mini
not,
bypass.
Mini bypass. Not sleep, mini bypass. So you definitely want to keep that in mind. It's, they're kind of the same in terms of results.
Right.
And then so some of the cons with it, I feel like the RY has more cons. There's more reasons why you wouldn't want an RY over a mini bypass. And to me, the main one would be that it's not really revisable. Well, it is.
But it's a very high failure rate.
Well, yeah. So if you have an RY and you revise it, you can only revise to an RY. And so so you can have like a distal, so they bypass more intestine technically. And so, but the prognosis for additional weight loss is a lot less. It's pretty low.
And you're not guaranteed to lose anything.
You're really not. And so
you don't guarantee that.
The RY surgery would not be right for someone who's like 20 years old and has no other serious health complications. They don't have reflux from like esophageal cancer or genetic disposition that causes GERD or something like that. Because they would be putting all their eggs in that one surgery's basket, and they wouldn't have any room for revisions.
Right.
Nobody, some people plan on doing 2 surgeries to lose weight. That's usually recommended for really higher BMIs.
Yes.
But for the most part, most of us don't go into surgery thinking that the surgery is going to, nobody goes into it thinking it's going to fail, or that it's at some point, you're going to have weight regain.
Right.
People tend to think that they want this particular surgery. They say, I want the full bypass because I don't want to gain my weight back.
Or I don't want to have a second surgery.
And so the thing about it is, I don't care what surgery you have, you can gain weight back.
You can gain weight back.
You can. And so especially for like that younger person, that 20-year-old, life is going to happen.
You're going to have kids.
Yeah, females are going to have children.
You're going to gain weight. You might get through menopause.
Yeah.
All kinds of reasons.
So I always say life happens.
That's
you can have a physical trauma. Physical traumas can limit mobility, which could potentially cause weight regain. You could have an emotional trauma. If you have an emotional trauma, you may become depressed, or you may, what we say, eat your feelings.
Yes.
All those things could result in, or just we gain weight naturally as we age.
Right, and men too. We shouldn't limit it to women. Having kids and menopause. I mean, men can have a physical trauma or emotional trauma and not, be able to.
Right. And so if you put all your eggs in that RNY basket, then you don't really have a lot of options for additional weight loss. So that to me is one of the biggest cons of this surgery. I feel like if you have that reflux from for those reasons, the genetic disposition or the esophageal cancer, then RNY is definitely your surgery. That is when it is definitely your surgery. And so a lot of people tend to think that this surgery is for higher BMI, like we were talking about, and it's just not. It's not how it works. Another con to this surgery is that because they're connecting two different portions there in the intestine, there's more risk of like leaking or complication, bleeding.
It's a higher risk surgery.
Yeah, and this surgery seems to have more vomiting associated with it. Probably because of the tiny little stoma. Don't you think? It's just less stomach.
Right.
That would make sense to me.
Yeah. Another con, vitamins for life.
Oh, yeah, for sure.
You have to take vitamins for life. It's so important that you take vitamins because of the malabsorption, and you want to take good vitamins. Don't skimp on your vitamins.
No,
Don't.
Don't get cheap vitamins.
We've seen what happens.
Take Flintstones.
No.
You can't take Flintstones with these malabsorption surgeries.
No.
You just can't do it. I mean, you can, but you're doing yourself a disservice.
And have your levels checked on a regular basis to make sure that you are getting what you need.
Yeah, with any of the malabsorptive procedures, the tube bypasses and of course the DS, you want to do your lab. So, of course, the first 3 months, every 3 months for the first year, but you really want to do them every 6 months for life.
Right.
With those procedures.
A lot can happen in 6 months.
It really can.
A lot can happen in 3 months. You want to get everything right.
Exactly. So that kind of concludes that surgery. There is a lot about it. Definitely take a look on the website. You can see the anatomy and what it looks like on the website. I'm a visual person. I like being able to look at it. And you'll see the little Y shape.
Some good illustrations there.
Yeah, some really good illustrations.
Very good.
Yep, so that kind of wraps that one up.
So now we're moving on to the mini bypass.
Mini bypass. Hey, Sarita, you know what bugs me about the mini bypass?
It's not mini?
It's not mini!
It's not mini.
There's nothing less than about it. It's the statistic, so the results are statistically like the same. And it's not less than anything.
Sounds less because
it sounds less. Mini. So the technical term for it is single anastomosis bypass.
That's longer.
It is. So they should call it mini bypass. Yeah. I think too they call it that because you're connecting one.
That makes sense.
Portion instead of two, but it's not less than by no means. And so, how do we do a mini bypass? Is it laparoscopic too?
It's laparoscopic, 3 to 5 incisions, same.
It is. So that part is the same.
Right.
And so this is something I know you know about. What kind of stomach do you have?
I have a banana.
I have a banana. And so with this surgery, a normal stomach is a cantaloupe, and with a sleeved stomach, you have a banana. So with a mini bypass, you have a sleeved stomach.
Right. So they remove the hunger hormone.
They do. They remove it completely, 80 to 85% of your stomach. So you're reduced down to a banana.
Not an egg.
Not an egg. You still have a banana. And so that makes the surgery more advisable, but we'll get into that. And so then in addition to that little banana, they're like the sleeve, they're also going to reroute some intestine.
Right.
So technically they're going to reroute the single anastomosis connection of the small intestine and not that double that makes the Y.
Right.
Again, I'm not good at explaining that, but the website, the diagram, the illustrations on there.
Yes, you can see all the pictures. You can compare them.
And we should probably put the link. There's a whole page that has them side by side. So those two illustrations are literally side by side, and you can see the difference. And the whole page is a comparison of the two surgeries. If you need to go find it, if you hover over procedures, hover over mini bypass, you can click on mini bypass versus RNY.
Yes.
And that page is one of my favorite pages to share with people who want to understand the differences. I love that visual. Yes. So pros and cons of this surgery.
Yes.
Of mini bypass.
So one of the pros is that it is revisable to a DS.
Yes. You know what? It is also revisable to RMI. Because it is because you have that little banana stomach, and now they can still make you a little egg stomach by cutting that off and adding that connection. So it is revisable in 2 different ways, technically.
Yes.
Well, 3 because there's 2 DSs. But anyway, this surgery, if you have reflux from being overweight or bad food choices, because your food choices should change through surgery, weight's going to be lost, or if you have a hiatal hernia, then this surgery is going to help with that because you're going to repair a hiatal hernia, lose weight, make better food choices.
Right.
And so in that situation, if that's what you have reflux for, then it would help.
And this procedure has a lower risk.
It does. You're not connecting as many parts in there.
Yeah.
So yeah, it's a little bit lower risk, making it a little safer. And also, again, a pro to me is statistically it produces the same results in terms of that 75-ish% of excess fat lost, and both of them have that.
Same con.
Same con.
Vitamins for life.
The one same con.
One same.
Yeah, I really only find that there's that one con with this surgery. And if you're wanting a more aggressive procedure, it's not really a con because that's an expectation of a more aggressive procedure. I feel like this surgery is a great option for anyone who wants something more aggressive and doesn't have that reflux from like the genetic disposition and the esophageal cancer. And I always say that because I want you to understand that reflux can be caused for other reasons.
Right.
And so it's really a great procedure, in my opinion, if you want something more aggressive, because of the revisable. To me, that's the best thing about it, being revisable.
I don't want another surgery.
I know.
I just want one.
You're killing it with your surgery.
I'll be 6 years post-op next month.
Yay! Okay, so that kind of really wraps up the comparison of the two. It is our goal to help you make a informed decision for surgery, so that's why we want to share all this with you.
We hope this helps.
Yes, we do. We really do hope it helps. You can always call, text, or email us. Our information is on here. We have our surgeon liaison if you want to talk about maybe some medical questions and things like that. She's available to help you, to help our patients with that. And then drop us a comment. What do you think?
Yes, drop us a comment. We need more comments.
Yeah, drop us some comments.
Yeah, we like to know what feedback, like what you think. And
yeah, for sure. And you can always email us questions.
Yeah, email us questions.
If you have like a podcast topic you want us to talk about or anything, just send it to us.
Right.
We
would love to.
Absolutely.
Yeah, have that feedback so we can get some more podcasts out there.
Yes. So, have a great day.
Thank you.
Thanks for tuning
Bye-bye.
in. Bye, friends. If you have any questions or want to share your bariatric weight loss journey, you can call or text us at 480-999-4826 or send an email to podcast@mexicobariatriccenter.com. You can also follow Mexico Bariatric Center on Facebook, Instagram, and Twitter. Keep in mind, these are the opinions of the host. The views represented do not reflect or define the values of Mexico Bariatric Center. This podcast is sponsored by Emerge Bariatrics and Mexico Bariatric Center. Please visit mexicobariatriccenter.com for more information.